Okay, so we are going to discuss benign melanocytic neoplasms for this lecture. So the outline for this lecture will be to cover Ephelides and Lentigines, dermal melanocytosis and related conditions, common nevi and dysplastic nevi, nevi of special sites and recurrent nevi, Spitz nevi and related conditions, halo nevus, balloon cell nevus, Meyerson's nevus or Meyerson's nevus, and Nevus of Nanta. So Ephelides or Ephilides or freckles are small pigmented macules. They only show up on sun-exposed skin, and they show up on individuals with fair skin. They tend to fade and reappear and darken with sun exposure. And there's a genodermatosis called neurofibromatosis, where these freckles essentially are occurring mostly in the axilla or groin region, and that's called the crow's sign. Xeroderma pigmentosum is another genodermatosis, and these lesions are typically darker and much more numerous. Here's another example of a clinical picture here with a patient with a lot of freckles or ephelides. And essentially you can see that it's mostly on his sun-exposed face here. Oftentimes these occur in patients with red hair, and there is a gene called MC1R that regulates the development or the risk of pheomelanin, which is highly associated with red hair and freckles. So Ephelides pathology includes normal epidermis. Typically on pathology, you see no elongation of the reedy ridges and no nesting. If you saw a nest, that would make it a junctional nevus. Typically, Ephelides are hyperpigmented with basal keratinocytes, where the basal keratinocytes actually have a lot more pigmentation in the cytoplasm donated by the melanocytes, but the actual number of melanocytes is diminished or normal. So you have an increase in melanin, but not the number of melanocytes. If you had an increase in number of melanocytes, that would put you more in the lentigo category, and we'll discuss that, or melanocytic hyperplasia. So people have actually characterized the electron microscopy of these lesions and found that melanocytic dendrites are more numerous, they're longer, and they're increased. And this results in increased transfer melanosomes to the keratinocytes. So in an Ephelides, there is epidermal hyperplasia, or hyperpigmentation rather, but no lentiginous epidermal hyperplasia is evident. Here's another example of that hyperpigmentation of the epidermis. So lentigines, by definition, are hyperpigmented macules that have increased number of epidermal melanocytes, but no nesting of melanocytes as you would see in a nevus. So again, it's in between a nevus and an Ephelides. So you have a lentigine that has just that increased number of melanocytes, increased pigmentation because of that, where you get that hyperpigmentation with the increased number of melanocytes, but no nesting of the melanocytes. Lentigo simplex. These show up clinically as a brown macule with early age of onset, with little to no relationship to sun exposure. The epidemiology includes all races, and they're equally in both sexes. These are a list of genodermatoses that are associated with multiple lentigines. I'll have you take a look at that. So you can see a list of genodermatoses that are associated with multiple lentigines, and I will not read this list to you, but it's there for reference. We will go over some examples. So this is an example of Peutz-Jeghers, where you see lentigines that are dark brown to gray and blue. They often appear around the lips, around the mouth, and on the fingers. These are often macules, which may over time disappear. The macules of the buccal mucosa are blue to blue and black and are pathognomonic. So you see this kind of bluish to blackish color around the lips. If you get a Kodachrome of that, you should definitely be thinking Peutz-Jeghers. Peutz-Jeghers syndrome is a result of an autosomal dominant defect in the STK11 or LKB1 gene, which is a tumor suppressor gene. And this would explain why you have an increased risk of malignant transformation and association with many different types of cancers, including GI adenocarcinomas, breast carcinomas, pancreatic and endometrial cancers, and Sertoli cell tumors. For all the nail fans out there, these patients also gain longitudinal melanonychia. Here is a Kodachrome of leopard syndrome. So leopard is an acronym that stands for lentigines, EKG abnormalities, ocular hypertelorism, pulmonary stenosis, abnormalities of the genitalia, retardation of growth, and sensory neural deafness. And so taken together with all of these features, that gives you leopard syndrome. Why are we talking about it right now? Because these patients often have lentigines around the face, around the mouth, very similar to Peutz-Jeghers. They can have it all over the body, actually. Widespread lentigines and several cafe au lait macules as well. Here is an example of lentiginous lesions in atrial myxoma syndrome complex. This is also known as Carney complex. And this child has what we call LAM or name syndrome. And we'll get into what that stands for. Carney complex, also known as name-LAM syndrome, is a result of an autosomal dominant defect in the gene PRKAR1A. These patients have many lentigines involving the centrofacial, mucosal, and conjunctival areas. These patients often have red hair, epithelioid blue nevi, pseumomatous melanic schwannomas, and atrial myxomas. They can also have multiple tumors, including pituitary adenoma, which results in acromegaly, Sertoli Leydig cell tumors, pheochromocytomas, and primary pigmented nodular adrenocortical disease. The acronym NAME stands for nevi, atrial myxomas, myxoid neurofibromas, and ephilides. And then LAM stands for lentigines, atrial myxomas, mucocutaneous myxomas, and blue nevi, particularly of the epithelioid type. So what do we see on path for lentigo simplex? Like I said earlier, we see an increased number of melanocytes in the basal layer. Lies focally contiguous to the near tips and sides of the elongated rete. But the most important thing is that you have no contiguous proliferation between the rete and no melanocytic nest. So if we had contiguous proliferation, that would be more concerning for a melanoma in situ, especially if you had contiguous proliferation coupled with pagetoid upward migration. If you've got no melanocytic nest, by definition, that's not a nevus. So increased melanocyte concentration, but not nesting, that is going to lead you more towards a lentigo. Lentigo simplex usually lacks significant solar elastosis, in contrast to a solar lentigo, which has a lot of solar elastosis. So here's a lentigo simplex. You can see the elongation of the rete ridges here, and hyperpigmentation, as well as increased numbers of solitary melanocytes. Lentigo simplex, again, just another example of the melanocytes where they're pretty round with normal sized nuclei. They're cytologically bland. They're surrounded by that retraction artifact, but nothing worrisome here. And no nest. Nest will be defined as like basically 3 melanocytes together, 3 to 5 melanocytes, depending on who you get your definition from. But if you've got at least 5 melanocytes clustered, especially at the base of the rete ridges, you need to classify that as a junctional nevus. Mucosal melanotic macules are also very common. These include brown macules occurring on a mucosal site with little to no relationship to sun exposure. These often occur on the vulva, most often on the labia minora, the penis, and the oral mucosa as well. Here's an example of the mucosal melanotic macules. You just see these flat brown macules around the mucosal surfaces. In isolation, people may be worried about a mucosal melanoma, and this is why these are often biopsied. Genital melanosis and lentigines can occur in several conditions, such as log A Hunziker, Carney complex, and Banyan-Riley rubicolba. We talked about Carney complex having a defect in PRK1R, and the Banyan-Riley rubicolba is associated with a P10 mutation. The same with Cowden's disease, P10 mutation. What's the histopathology of mucosal melanotic melanoma or mucosal melanotic macules? These are hyperpigmented lesions in the basal layer. They've got broad, squared off reedy ridges. You have a slight increase in the number of melanocytes at the dermal epidermal junction, and these can be essentially a normal increase. It's within that range of upper limit of normal increase in melanocytes along the dermal epidermal junction. But importantly, no contiguous proliferation of melanocytes. Here's an example of a mucosal melanotic macule. You can see this hyperpigmentation along the basement membrane. You often have acanthosis of the epidermis as well, but you can see that the keratinocytes are relatively bland, and you do not have any apparent melanocyte proliferation here. Here's an example of a labial melanotic macule. You can see that you're on a mucosal surface because you have pale oral mucosal epithelium showing intense pigmentation of the basal layer. There is a link between PUVA, sunbed, and radiation lentigines. These lesions are typically multiple and present as hyperpigmented, highly irregular macules with a predilection for the shoulders, the upper back, and the limbs. On pathology, you get this ephelid-like features with lentigo-like features, and rarely you have melanocytic nuclear hyperchromatism and pleomorphism and multinucleation. Solar lentigo or actinic lentigo, as the word solar implies, mostly occur on sun-damaged skin in older patients with fair skin with a lifetime of sun exposure. Sites of predilection include the face, the back of the hands, and the forearms, and it's associated with chronic sun exposure. Here's an example of the diffuse solar lentigos on the bilateral dorsal hands, as well as the bilateral legs in this picture. It would be difficult to examine each one of these lentigines in a single clinic to look for melanoma, and so it becomes more high yield to look for any lesions that are actually exhibiting an ugly duckling sign, that are larger, that have variable pigmentation. The same thing that we look for when we're evaluating for melanoma. You just have to look within the background of a very highly variable pigmented skin. Solar lentigo histopathology includes epidermis, which shows elongated reedy ridges that often appear club-shaped or fused to form a reticulated pattern. This increased basilar pigmentation, especially in the reedy, is known as dirty feet or dipped in chocolate appearance. The number of melanocytes are often increased, but not always. And the melanocytes are by definition not contiguous, and there are no nests. So if you did have contiguous growth, that would make it worrisome for a melanoma. If you had nests, that would make it a nevus by definition. If you had contiguous growth and nests along the dermal epidermal junction with pagetoid spread, you would be dealing more with a melanoma in situ. The upper dermis often shows solar elastosis and solar lentigos, as you would expect. Here's an example of that dirty feet appearance. You see a solar lentigo that has hyperpigmentation at the base of the reedy ridges, and that's where you get that dirty feet or dipped in chocolate description. And the upper dermis has a bluish appearance to the collagen, which is known as solar elastosis. This is a picture of a solar lentigo, and in this field, you see some keratin pseudocysts, which actually resemble an adenoid seborrheic keratosis. But the important thing is that this is a lentigo because you have increased melanocytes at the base of the reedy ridges. You also have solar elastosis in the upper papillary dermis. Even if you see these pseudo-horn cysts, it doesn't mean that you have a seborrheic keratosis. It's you could describe that in your report that you're getting some seborrheic keratosis-like change, but there's definitely a lentigo here. Here's another example of solar lentigo with increased numbers of basally located melanocytes within a characteristic retraction artifact. But there's no cytologic atypia here to make you worried about a dysplastic, junctional, or even evolving melanoma in situ. Ink spot lentigos are rare variants of solar lentigos. They're typically solitary, highly irregular reticulated black macules. And they usually measure about 6 millimeters or more in diameter. They're clinically mistaken for melanoma. They often have a very marked basal cell hyperpigmentation with normal to slightly increased numbers of melanocytes and pigment incontinence. Here is an example of an ink spot lentigo. And on pathology, it almost looks like a tattoo at the base of the reedy ridges because you've got intense pigmentation. The melanin is so dense that it looks almost black here. And it's present along the stratum corneum. Now, the only time you should see black pigment is in a tattoo. This is technically very dark brown due to the increased concentration. Becker's nevus is known as a nevus because on clinical exam, it looks like a hyperpigmented, potentially congenital nevus, but it's also known as a Becker's melanosis or Becker's pigmentary hamartoma because you can have hyperpigmentation in the basal layer, but this is truly a rare hamartomatous condition that has predilection for the chest as well as the shoulder and upper arm. It often occurs in males much more than females. So you can think about Becker being a male's name and Becker's nevus. It occurs more in males than females. The patients usually present in late adolescence or early adulthood, classically after intense sun exposure with gradual enlarging unilateral pigmented macular lesions, which subsequently develop hypertrichosis. And I would say that the hypertrichosis gives it away clinically. The rare associations include breast and limb hypoplasia, limb asymmetry, pectus excavatum, spina bifida, scoliosis, and lipoatrophy. So here's an example of a Becker's nevus. You can see that it's isolated to the left back side of this gentleman here, and you see that hypertrichosis along an area of a pigmented plaque. On pathology, you get hyperkeratosis, mild hyperkeratosis with variable acanthosis, elongation of the reedy ridges, and that increased in pigmentation of the basal keratinocytes. So it's not a nevus in the traditional sense. It's really a hamartoma that has increased pigmentation of the basal layer. You do have pigment incontinence present and variable presence of dermal smooth muscle, which will allow for you to make the diagnosis. If you're given this hamartoma, you're going to really need to key in on the presence of smooth muscle. Now, it can have clinically something called a pseudodariase sign. If you stroke the lesion, it will stimulate the hamartomatous smooth muscle to cause a retraction in the lesion. This is just a picture of an acanthotic hyperpigmented epidermis with focal bundles of smooth muscle in the dermis. This is a deeper view of that same lesion. You can see the bundles of smooth muscle extending all the way down to the deep part of the dermis. We'll next talk about congenital dermal melanocytosis or Mongolian spots. So congenital dermal melanocytosis is very common, especially in African Americans and Asians. Clinically, it's present at birth. It's most common in the lumbosacral area. And you have blue to gray macules or patches. They can be anywhere from 2 to 10 centimeters, resembling what some people think looks like a bruise. They usually spontaneously resolve during childhood. And they look like this clinically. So you have this kind of slate bluish to grayish, ill-defined patch and small even macules that are forming on the lumbosacral region all the way up to in between the scaphoid areas or the scapula areas here on the back of this patient. And this is really the classic Mongolian spot that you would need to be able to recognize. Now, of course, they can be aberrant and have extra sacral Mongolian spots as well in the back, but the classic is going to be this lumbosacral area right here. So in histopathology, you have an epidermis and a papillary dermis that are pretty much unremarkable. It's not going to catch your eye. But the action is in the reticular dermis, where you have the slender, slightly wavy dendritic melanocyte population with variable amounts of pigment. They're present in low concentrations and they're widely scattered between collagen bundles. They're usually oriented parallel to the epidermis in east-west appearance in the lower 1/2 of the dermis. No melanophages and no sclerotic stroma. Here is an example of a Mongolian spot. So it looks pretty unremarkable. But on higher power, you're going to find those spindled melanocytes in increased concentration. And so without the clinical, it would be a little bit hard to make the diagnosis, but with the clinical, you should definitely key in on Mongolian spot here. Nevus of Ota and Nevus of Ito. So I have the longer names there listed for reference. Nobody usually says oculodermal melanocytosis or Nevus fusoserilis acromiodeltoideus because those are really long. So Nevus of Ota typically refers to these macules around the ophthalmic and maxillary branches of the trigeminal nerve or the periorbital region. I think of the O in orbital and the O in Ota. Nevus of Ito is very similar, but it's in the skin distribution of the acromioclavicular area or the shoulder and back. And I typically think of the eye as close to the arm. An eye is shaped like an arm. So you can think about that on how to remember those quickly. Epidemiology, these are predominantly in darkly pigmented individuals, especially Asians and African Americans. And the significance is they're essentially benign, but the malignancy has rarely been reported. And in the majority of those, it's been associated with the ocular nevus of Ota. Here's an example of the Nevus of Ito clinically. You can see that kind of dark gray to brownish patch. It's very large in the acromiodeltoid region. And the Nevus of Ota in a 20-year-old woman, you can see this hyperpigmentation around the orbit. And that hyperpigmentation can even extend into the sclera. On path, you're going to see the epidermis is relatively unremarkable, but in the superficial and middermis, you're going to have scattered but numerous deeply pigmented and elongated dendritic melanocytes in the upper 1/3 of the dermis. You shouldn't expect melanophages. You could have some melanophages, but that's not where the pathology is. The pathology is spindled dendritic melanocytes. You shouldn't expect to see any sclerotic stroma. Again, it's really this bland stroma and collagen background, and then these spindled melanocytes. The prognosis is that there's no tendency to spontaneously regress, so they can be there for quite some time. But you can target these with lasers such as INDA-YAG as well as ruby lasers, depending on the skin of color background. So Nevus of Ito and Nevus of Ota, very unremarkable. You see this foci of pigmented spindled melanocytes in the dermis. Again, on higher power, you see those spindled melanocytes, the dendritic melanocytes. The collagen background's pretty unremarkable. Here is an example of a bilateral pigmented lesion that's very similar to Nevus of Ota. However, it's known as acquired Nevus of Ota, like macules or hoary nevus. These are blue to brown slate gray patches on the lateral sides of the forehead, the temples, the upper eyelids, as well as the malar areas and the roots of the nose and the ala nasi. Women of Asian descent in the 4th and 5th decade are the ones that typically get this. Differential diagnosis includes melasma, as well as Nevus of Ota and Reals melanosis. They typically have no ocular, tympanic membrane, or mucosal pigmentation, and they often have a later onset versus Nevus of Ota. Histologically, you see irregularly shaped bipolar melanocytes in the middle and upper dermis without disturbance of the normal skin architecture. And on electron microscopy, these typically have they show melanocytes that contain many single dispersed melanosomes in stages 2, 3, and 4 of melanization. This distinguishes horae nevi from Rehl's melanosis and dermal melasma. Moving on to the common acquired melanocytic nevus. So these are known as nevocellular nevi. Clinically, they're well circumscribed, they're symmetric, they're round to ovoid lesions. Typically, they're usually 2 to 6 millimeters in diameter. They may occur anywhere, and they have a variety of morphologies, which we will discuss. The epidemiology, typically these occur in the first 3 decades. Most appear in adolescence or early adulthood. They occur mostly in fair-skinned individuals and in increased sun exposure. The significance of these, they're a potential precursor to melanoma, and they have increased numbers of nevi seen in families with familial melanoma. So you can think about a melanoma arising from any melanocyte. So if you have lesions that have a higher concentration of melanocytes, that makes it more statistically likely that you're going to develop a melanoma. So patients with higher numbers of nevi are at a higher risk to develop a melanoma. Clinically, junctional nevi are known as, or are usually seen as pigmented macules because they only have nests in the epidermis. So they don't have a lot of robust clinical presentation, just these flat pigmented macules. Compound nevi are usually pigmented papules, and that's because they've got junctional components in the epidermis, but also dermal neval components. So you get a pigmented papule with a papillomatous lesion. Sometimes you get papillomatous lesions. And then an intradermal nevi, these are typically flesh colored to pigmented. They lose their pigment oftentimes because they're deeper in the dermis. That gives them more of a skin colored appearance. They're dome shaped, they're usually soft, they can be papillomatous or they can be pedunculated. Junctional nevi, like I said, are usually just flat brown macules. They can be round, they can be ovoid, they can be elongated like this. They can have somewhat of an irregular border as well. It doesn't necessarily mean they're dysplastic or melanoma in situ, but oftentimes junctional nevi are biopsied, especially if they're a lone nevus and they give off an ugly duckling appearance. But clinically, they're usually just macules such as this. The compound nevus here rather develops into papules, and you have these brown papules. Many times they'll even have hairs extruding from the papule. You'll have more pigment on the top compared to an intradermal nevus. So here are some examples of compound nevi. An intradermal nevus, it's becoming more lighter in color. The top looks a bit more skin colored or the same color as the surrounding skin. And that's because the melanocytes are just deeper seated within the dermis. There's usually no junctional component identified on histopathology. So common acquired melanocytic nevi are defined histopathologically by the presence of nevus cells. So what are nevus cells? Nevus cells are melanocytes that are situated within a nest, and that can be defined as either 3 or 4 or 5, depending on who you talk to. The important thing is that you've got a lesion that has aggregates of melanocytes, usually at the base of the reedy ridges and junctional nevi, and they're usually nesting together in the dermis. And at that point, they're usually more than 3, not always, but they can be 5, 6 to even 10, up to 20 melanocytes in the same nest, and even higher depending on how creative the nevus is that you're looking at. It can be arranged in clusters of nests or theque patterns. Theque means that it's a linear kind of cord that's going parallel to the epidermis. If you see a theque-like pattern, it can sometimes indicate a little bit of a red flag for melanoma, so that's something to keep in mind. Nevi have a propensity to retain pigment in the cytoplasm rather than to transfer it to the neighboring keratinocytes. They tend to be round rather than dendritic in shape. So on histopathology, junctional nevi tend to have nests of melanocytes confined to the epidermis, mainly at the tips and the sides of the ridges. Compound melanocytic nevi have nests of melanocytes present in both the epidermis and the dermis. In the dermis, they display maturation, which we will talk about. And the intradermal nevi are nests of melanocytes combined to the dermis, and they often show maturation as well. So what do we mean by maturation? Do we mean making better decisions as we get older? No. In terms of melanocyte language, maturation means type A, superficial, type B, mid-dermal, and type C, deep populations that display these features here. So type A exhibits pigmented epithelioid round to cuboidal cells with abundant cytoplasm, whereas type B usually shows non-pigmented, small, round, scant cytoplasm, and they're often arranged in cords. And these are lymphocyte-like. That's how small they become. Type C, though, are the deep melanocytes, and these are often spindled, wavy, and non-pigmented, and they are what is described as neurotized because they look so much like neural cells. They actually tend to resemble fibroblasts in many ways. But if you were to stain all of these cells for SOX10, a nuclear marker for melanocytes as well as neural cells, they would all stain positive for SOX10. So by definition, they are SOX10 producing cells. Here's a junctional nevus. You can see nests of aggregating nevus cells along the junction here. There's nothing in the dermis. Compound nevus has a nest of melanocytes, and you can see at least one junctional melanocyte. This is also probably a junctional melanocyte, but it's cut out of the section to show you the connection to the overlying epidermis. And then all of these down here are well-nested dermal melanocytes with very bland cytoplasm. Intradermal nevi are, again, nevi that have all of their nested melanocytes in the dermis. Now, yes, you do have melanocytes in the junction of an intradermal nevus, but they're not nested. So an intradermal nevus oftentimes has solely nests within the intradermal or within the dermal space. Now, we often do look at all of the epidermis because if we find one nest, even one single nest in the junction, we change the diagnosis from intradermal nevus to compound nevus. And the reason that that's important is because most melanoma in situs are arising from junctional melanocytes. And so it becomes important to really examine that overlying epidermis for junctional melanocytic nests, as well as melanocytic contiguous growth and pagetoid migration. So when you see a predominantly intradermal nevus, you need to actually zoom in on the epidermis and examine to make sure there is no overlying melanocytic proliferation in the junction. Congenital melanocytic nevi are characterized by melanocytic nevi that are present at birth. And they have histologic features suggestive of a congenital onset. Usually they're slightly raised, symmetric, and they have lots of hair growing from them. That's the hypertrichosis. If you remember the intermediate size cutoff, which is 1.5 to 19.9 centimeters, then you can easily remember the small and the large size. So small is going to be less than 1.5 centimeters in diameter, and the large or giant are going to be greater than 20 centimeters in diameter. Patients with the large congenital melanocytic nevus are at higher risk for neurocutaneous melanosis with posterior axial locations, satellotosis, and large size. The significance here is that there's an increased melanoma risk with large congenital nevi up to 12%, especially in extracutaneous melanocytic nevi, and most of these develop by puberty. Here's an example of a melanocytic congenital nevus. This looks to be about 1 centimeter in diameter, but they can get quite larger as well. And so here on the right-hand side, you see this extensive melanocytic nevus, congenital melanocytic nevus. And when these patients come into clinic, you have to examine all of these areas to make sure that there's no malignant transformation of melanoma here. The key takeaway for this lecture is the pathology. So diffuse maturing melanocytes are seen in congenital melanocytic nevi. They're often broad. They have a band-like pattern in the superficial dermis. They may exhibit infiltration to the lower reticular dermis. They have extension of the melanocytes between collagen bundles, and that looks as a splaying, separating pattern of collagen in single or double rows. So it's really separating out that collagen. And the key takeaway is that the melanocytes in a congenital melanocytic nevus are adnexocentric as well as angiocentric and neurotropic. So they surround the adnexal structures, they surround the blood vessels, they surround the nerves. And to the untrained eye, this may look worrisome for melanoma, but what you're going to need to know is that these are not melanoma, they're congenital melanocytic nevi. So here's a picture of just how concentrated these nests can be, how folliculocentric, adnexal-centric, vasculocentric they can be. A lot of pigment production as well, especially in the superficial melanocytes. Now, if you have an intradermal nevus that wraps around a hair follicle, that's known as a congenital growth pattern. So sometimes we sign cases out as compound nevus with congenital growth pattern or intradermal nevus with congenital growth pattern. On higher power, though, you can notice that the melanocytes in a congenital melanocytic nevus are very bland. There's no nuclear pleomorphism, there's no mitotic figures. For all intents and purposes, these look just like normal melanocytes, except they're adnexocentric, vasculocentric, etc. They can surround nerves, so just expect that. Moving on to blue nevus. Blue nevi are blue to black firm papules or nodules. They often occur in childhood or adolescence, but they can develop in adults as well. You can have rare malignant transformation in blue nevi. And so it's important if you see a blue nevus to try to at least sample as much as you can, because if you don't get deep enough on a blue nevus, then you kind of leave the rest up to imagination. So blue nevi definitely can have malignant transformation arising from them. And so if you see a small blue symmetric papule and you can get it out with a punch biopsy or a small excisional biopsy, it's better to do so. Multiple blue nevi has been associated with the Carney complex, as we discussed before. And the most commonly mutated genes that you'll have to know for your exam are GNA11 as well as GNAQ mutations. Common blue nevi types include the solitary dome-shaped papules that are typically between 0.5 and 1 centimeter in diameter. 50% are on the dorsal hands and feet. That's the common blue nevus. Cellular blue nevi typically present as solitary nodules or plaques 1 to 3 centimeters in diameter, commonly on the buttocks, the sacrococcygeal area, and the scalp. Combined blue nevi usually consist of epithelioid or deep penetrating forms. These represent 1% of all excised melanocytic nevi. The most common presentation is on the face, and they resemble other blue nevi clinically. The epithelioid variant typically is associated with Carney complex, but there's no sclerotic stroma in these, as opposed to a sclerosing blue nevus. The deep penetrating nevi, on the other hand, are typically composed of melanocytes with small hyperchromatic nuclei. They've got the smoky cytoplasm. They have smudge chromatin pattern, and they have inconspicuous nucleoli. Here's an example of a common blue nevus clinically. I wouldn't blame anyone if they wanted to rule out melanoma here, especially if the patient wasn't sure how long it's been there and says it was growing. Melanoma and blue nevi can look very similar clinically, so definitely want to biopsy this as much as you can to remove almost all of it to get the pathologist the best look at it. Here's another example of a small common blue nevus. You could definitely do a shave removal or a punch removal of this, depending on the patient's preference here. I'd probably do a punch just to replace it with a small scar. Common blue nevi on path typically have a normal epidermis, but in the dermis is where the action is. You have a symmetric proliferation of pigmented dendritic melanocytes, and the way that those pigmented melanocytes bounce off light results in what we call a Tyndall effect. So you've got pigment that reflects light and it becomes a blue color to the viewer's eye. And so that's where you get the blue nevus. So the pigment in a blue nevus is the same brown pigment that you see anywhere else in any other melanocytic lesions. It just, the depth of that pigment allows for it to look blue when viewing it visually. The melanocytes are usually larger and more dense than in dermal melanocytosis. The melanocytes are slender, they're elongated, they're oriented parallel to the epidermis. They can track down hair follicles as well. In these nevi, you actually have increased fibroblasts and collagen, which gives it a fibrotic appearance. And melanophages are frequently seen, but the melanophages themselves are not the important part that makes up the blue nevus. But if you were to stain a blue nevus for SOX10 and look for nuclear positivity, you would see that most of the lesional cells are associated with SOX10 positivity, and that just essentially proves that it's pigmented melanocytes. Here you can see kind of an atrophic epidermis here and a sclerotic or fibrotic with the underlying sclerotic or fibrotic background. You have nevus cells that are in all levels of the dermis. You have spindle-shaped cells with in between collagen bundles, and these spindle-shaped cells are very pigmented. So here's that common blue nevus appearance. You see, if you've never seen this before, you may be kind of surprised that it's a nevus, but it is a pigmented spindled melanocytic proliferation. And this is the classic appearance of a blue nevus. Cellular blue nevus clinically is more robust. They can be larger. You can again see that blue picture or that blue hue that's coming off of the lesion. They often have a normal epidermis as well, with bulky, heavily pigmented cellular proliferation involving the entire dermis. It's usually broader at the surface. And it usually has this dumbbell shape at the bottom, so it's bottom heavy. It enters the subcutis and it gives this cellular nodule at the base, and that's what gives you this dumbbell shape. They're composed of fusiform melanocytes with vesicular nuclei and prominent nucleoli, and they typically do not have maturation with depth. However, they do have neurotization. It's important to note that there's an immunostain called HMB45 that is normally expressed only in junctional melanocytes of benign nevi, and it decreases expression with descent into the dermis with normal nevi. Cellular blue nevi, however, are the exception. So they will have a strong HMB expression from the top all the way to the bottom of the lesion. So that can be tricky because melanoma can have the same immunophenotype. But it's just important to know that HMB is not the most specific marker in a cellular blue nevus to help you separate between melanoma. Here's an example of a cellular blue nevus, and you can see this bottom heavy proliferation that's like a dumbbell shape at the base of the biopsy specimen here on the right side panel. Another example of a deep cellular blue nevus with that deep, heavily concentrated pigmented dendritic melanocytic population. And you can see spindle nevus cells with that kind of splaying effect on the collagen there. You can have a combined nevus, which looks essentially identical to the other classic nevus, but on histopathology, you're going to have two components. One looks like a normal intradermal nevus or a normal compound nevus, and the other part looks more like a blue nevus. So that's where this common combined nevus comes from, where you've got basically a combination of a normal nevus and a blue nevus. You can have junctional, compound, or intradermal, rarely Spitz, and then a blue nevus component, which could be common or cellular. So here's an example of a common nevus. It's kind of more of a junctionally based nevus at the top, and then this transition to a combined nevus. And the thought is that maybe one of the nevus cells acquired some type of GNA11 or GNAC mutation that allowed a clonal transformation into the blue nevus cells. Another example of a combined nevus. Now, sometimes you have a deep penetrating nevus as a part of that blue nevus. And if you were to do a beta-catenin stain, it would stain nuclear for the blue nevus part, but it would stain cytoplasmic for the normal junctional, the normal nevus part. Moving on to dysplastic nevi. So dysplastic nevi are also known as atypical nevi or Clark's nevi. Some call them atypical nevi or nevus with architectural disorder. Some people sign these things out with cytologic grading as well as architectural grading. The important thing is these are not melanoma, but they're not quite a typical run-of-the-mill junctional nevus or compound nevus either. And we'll talk about the key criteria to kind of classify things as dysplastic or not. It can be controversial because it displays different morphologic changes. Some can be symmetric, but some can be asymmetric. Some can be small, but some can be large. Some can have regular borders, but some have irregular borders. And some can be homogeneous in color, while others show a lot more color variation. But at the same time, again, it's important to remember these are not melanoma. They're diagnosed. The most important thing about these is that they are not melanoma. But depending on if one grades them as mild or moderate or severe, they may be clinically treated differently. So another reason it's controversial is if you were to give one pathologist a slide of a dysplastic nevus and another pathologist a slide of a dysplastic nevus, they would likely grade them differently. At least if you gave them enough, there's not going to be 100% agreement. And so it's important to know that it partially depends on the sections you're looking at, and it partially depends on the perception of the pathologist looking at the sections that are available for examination. 50% of Caucasian adults and 5 to 30% of all nevi clinically or histologically are defined as dysplastic. Again, usually dermatologists are not going to biopsy something unless they think that it shows some type of clinically worrisome feature, and that's why you get a lot of dysplastic nevi on the biopsies. It's hard to sometimes tell between an early evolving melanoma in situ and a dysplastic nevi clinically, so it's just important to biopsy when there's any doubt. They often occur as sporadic lesions and in a familial setting, and having a lot of dysplastic nevi is an independent marker for an increased risk of melanoma. However, there's controversy as to whether melanoma truly develops from these, but I think that the patients that have a higher concentration of dysplastic nevi have a higher number of melanocytes and a higher statistical chance to develop a malignant melanocyte clone from all of those melanocytes that are getting UV damage over the lifetime, et cetera. So here is a clinical picture of a dysplastic nevus. You can see this patient's back has several enlarged brown macules and papules. Some of them look larger than others. There's some areas of clearing on the back, but there's a large variation as well. And so this would kind of give you this idea of the patient's background dysplastic nevi production, and then it would allow you to kind of assess any ugly ducklings. These types of patients, if they are able to, are often monitored with mole mapping, where you can actually track the moles across their back and look for any changes. Dermoscopy is very helpful in this setting because you can look at each dysplastic nevus for dermoscopic signatures to help you decide if you want to do a biopsy. Also relying on the patient's self-exam, although it's hard for them to examine their own back, but if they have a family member who's looking at their back, or they notice something on a visible part of their skin that's changing, that will also help key you in. And at the end of the day, if you're worried about a lesion, your gut's telling you to do a biopsy, it's probably just safer to go ahead and do the biopsy. So dysplastic nevi on path are separated into architectural features and cytologic features. So cytologic features include things like shouldering, where if you have a compound dysplastic nevus, you'll see a peripheral extension of the junctional component. Usually on both sides, greater than 3 reedy ridges beyond the dermal component. That's called shouldering. Lentiginous proliferation of melanocytic cells. So again, you can have this kind of almost contiguous growth along the dermal epidermal junction, but especially in between the reedy, not usually in between the reedy. You have bridging, which is probably the easiest to remember architectural feature. So that's where you have apparent fusion of the nest between the adjacent reed. You have asymmetry. So if you were to divide it in half, it doesn't look the same on one side or the other. And it depends on how that's sectioned for you to examine on the path slide. But if you see asymmetry, that also gives support for dysplastic architectural features. If you've got suprabasilar melanocyte distribution, or also more commonly known as pagetoid upward migration or pagetoid spread, that starts to put you in a category of dysplastic nevi. It could even be an indicator of melanoma. But you can have some pagetoid spread in regular dysplastic nevi. Fibroplasia is another favorite architectural feature. So if you see this characteristic layered fibrosis around the reedy ridges, which we'll show you an example of, that's called lamellar fibroplasia, and that's also very indicative of dysplastic nevus architectural features. Cytologic features on the right-hand column here, usually it refers to cell size. So if the cells are larger, and we usually think of mildly atypical dysplastic nevi as having the architectural features, but the cytology is such that the cell size is small, where the cells are basically the same size as the basal layer keratinocytes. The nuclear shape, so if the cytology has very pleomorphic nuclei, that could be an indicator. Nuclear stain or hyperchromatic chromatin can be an indicator. Nuclear size goes without saying. So if they're larger than the keratinocyte nuclei, we like to say if they're between 1 and 2, that signifies more of a moderate. On average, if the melanocytes are 1 to 2 times the size of the keratinocyte nuclei. And if they're greater than 2 times the size of the nucleus of the keratinocytes, then that starts to be, on average, that indicates more of a severely cytologically atypical dysplastic nevus. And again, you have to lack the other features of melanoma, but if you see worrisome cytologic features, then you can grade that as moderate or severe. Other features include melanophages or lymphocytic infiltrate. So it is possible to have a dysplastic compound nevus with mild architectural disorder, but severe cytologic disorder, or you could have a dysplastic compound nevus with severe architectural disorder, but only mild cytologic atypia. So it's possible to have different combinations. It becomes very confusing when you're trying to grade 2 separate parameters in a lesion, because that just increases the variability from one pathologist to the next. And so some people just grade these as mild, moderate, or severe, and they take into account architectural and cytologic features. So you could say atypical compound nevus with mild melanocytic dysplasia or moderate melanocytic dysplasia, severe melanocytic dysplasia. That takes into account both architectural and cytologic and gives a final grade as mild, moderate, or severe. There is an immunohistochemical stain out now called PRAME, which is highly associated with high levels of nuclear expression in melanoma, but not in dysplastic nevi. So that's something that has been somewhat helpful to push people more towards melanoma in situ or away from melanoma, depending on the PRAME expression. Again, PRAME stands for preferentially expressed antigen melanoma. And there's several papers that you can look at in the literature that establishes a high sensitivity and specificity. Of course, there's no perfect immunohistochemical stain that has 100%, because you're going back and looking retrospectively, and then you're looking at lesions and what they were called, and then you're doing immunohistochemistry after the fact. So understanding the true biology of PRAME and how it relates to melanoma and dysplastic nevi is still an evolving area of research, but it's pretty clear that the numbers are very highly supportive that lesions that have diffuse PRAME positivity in the nucleus greater than 75% are more often than not associated with melanoma as compared to benign or dysplastic nevi. Here's an example of dysplastic nevi. You can see the bridging between the reedy ridges. You can see that concentric lamellar fibroplasia. Here is a dermal component to the nest, and greater than 3 reedy ridges away, you get shouldering phenomena. So these are architectural features of dysplastic nevi. Just some more examples of dysplastic nevi. You can see the concentric lamellar fibroplasia, some areas of bridging between the reedy ridges. You can have an inflammatory response, which can also be considered as an architectural feature. Like I said, the grading of dysplastic nevi, typically low, moderate, or high grade. Low grade usually refers to atypia restricted to the shoulder region, and melanocytes are approximately the same size as the basal keratinocytes. Moderate includes atypia in both the shoulder region and the central portion. Some irregularity and confluence of the nest, and the melanocytes are greater than 1 but less than 2 times the size of the basal keratinocytes. And high grade usually involves atypical areas not entirely well nested at the junction, irregular nests, and may be marginal in distinction from malignant melanoma in situ. Also, the melanocytes are usually greater than 2 times the size of basal keratinocytes. Nevi of special sites include anatomic locations that tend to have atypical histologic features, making distinction from melanoma difficult. These include acral skin, the palms, the soles, the subungual region, the genital skin, including the scrotum, the pubics, the perianal region. The breast is also a special site. And then the flexural skin, including the earlobe, the axilla, and the umbilicus. Here's an example of a nevus on the acral surface. Acral nevi are essentially, architecturally, they can be somewhat worrisome because they can have a lentiginous component. They can have sometimes transepidermal elimination. They can have pagetoid spread. These are all things highlighted in yellow here. But usually they're circumscribed, they're symmetric. There's not a ton of shouldering happening. They have oval to vertically oriented large junctional nests. They have some retraction artifact, as well as the lentiginous component that's present, and they can have eccrine ductal involvement. And on cytology, the acral nevus has abundant pale staining or eosinophilic cytoplasm. They often have nuclei which are hyperchromatic or vesicular, variable cytologic atypia, and conspicuous nucleoli. They can have dendritic cells, transepidermal nest elimination, which can look very scary, pagetoid spread, which again can look very scary, dermal components which mature with depth, and that can be important, and absence of dermal mitosis. So the absence of dermal mitosis, I would say, is probably very helpful. I did do a study with the attendings of the Cleveland Clinic, Dr. Jennifer Coe and Dr. Steve Billings, Dr. Ronan, Dr. Fernandez, Dr. Piliang, and Dr. Bergfeld, as well as some of the other residents there at the Cleveland Clinic. And we looked at PRAME expression and acral melanocytic nevi in cases that were diagnosed as melanoma or dysplastic or Spitz or benign acral nevi. And PRAME, it was just kind of a lucky cohort, I guess, because PRAME was 100% positive in melanoma, and it was 100% negative in benign nevi. The cutoff threshold 75%, but the benign Spitz and dysplastic essentially had extremely negligible detection of PRAME, whereas the acral melanomas, going from acral melanoma in situ all the way to the very large nodular acral melanomas, were all very diffusely positive and darkly positive for PRAME in the nucleus. Way greater than 75%, probably close to 100% of the melanocytes. So that's where I really got my interest in PRAME, was this acral melanocytic nevi and melanoma project, where I saw firsthand how sensitive and specific PRAME can be as an immunohistochemical screen. And oftentimes we do not get very good biopsies from acral lesions because it's a difficult spot to biopsy. You may have some small samples. So having an immunohistochemical stain that can help you give a molecular malignant status to the nevus and have you rely a little bit less on architecture can be very important just to take into account when you're trying to make the diagnosis. Here's an example of an acral nevus to the untrained eye. This may look scary. You've got some large nevi or large nests that have probably hundreds of melanocytes in them. You have some areas that look like pagetoid upward migration. You've got some inflammation at the base of the redi ridges. So it can look scary to the untrained eye. And this is usually when benign melanocytes look scary to the untrained eye, that's called a special site nevi. So on special sites, you can see large atypical looking nests and asymmetry. It looks like the parent pagetoid spread, but the important thing is that these melanocytes are bland. You don't find mitotic figures very easily. And if you were to do a praying immunohistochemistry, this would be stone cold negative, probably 95 out of 100 times. If you get any detection at all, it's probably going to be very sparse and faint. It's not going to be diffuse dark like a melanoma. But I have had acral melanomas that some areas of the nest look very benign looking, but in the context, it was definitely a melanoma. And even those benign looking nests in the melanoma were heavily positive for praying, which is very interesting. So there's something about the molecular status of the melanocyte that is being revealed with certain new immunohistochemical stains. You could also do a Ki67 melan A double stain to look at the proliferation rate within the melanocytes. If you find anything 10% or greater, that's definitely very worrisome. And typically it will correlate with nuclear pleomorphism as well as presence of mitotic figures as well. Here's another example of an acral nevus. You can see the compact hyperkeratosis, which allows you to know it's on an acral surface. You see central buckshot scatter of the melanocytes, so that focal pagetoid, which can be present in up to 1/3 of acral nevi. And then these really well confined nests in the dermis, which have melanocytes. Another acral nevus at low power showing retraction artifact, transepidermal elimination of the nest in the pericardial cell layer and the stratum corneum. Again, that can look very scary to the untrained eye. And again, I mean, even to the trained eye, this could look very worrisome for melanoma in situ because you might think there's nests here, 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 single cells, some pagetoid. This looks like contiguous growth, pagetoid upward migration. But often with trauma to the lesion, because again, these are on acral surfaces, easy to be traumatized, you get transepidermal pigment elimination and other features that can be very worrisome looking. So doing IHC, for example, for praying could be very helpful because if it's negative completely, then that helps reassure you. What about persistent or recurrent melanocytic nevus or pseudomelanoma? So oftentimes benign nevi get biopsied and then within 6 months or sometime after there's a recurrence of the pigment. That's because some of the melanocytes were still there. It wasn't completely removed. It starts to reestablish a pigment network. Some of those melanocytes could even divide a little bit and persist up above the scab and that, or above the scar rather. And on histopathology, that can look very worrisome for melanoma and pagetoid spread. So what you get in these persistent or recurrent melanocytic nevi are variably pigmented macules, papules, or plaques with irregular borders. But the most important thing is they stay within the scar. So they stay within the scar from the previous biopsy. The pigment as well is also confined to the region of the scar. Once you have pigment production outside of the region of the scar, that becomes more worrisome because it looks like it's growing even beyond the bounds of the original procedure. It's not always 100%, but it is a worrisome finding that it could be something more malignant. Here's an example of a scar from a previous procedure, and you can see the melanocytic proliferation coming back within the scar. So for persistent or recurrent melanocytic nevi or pseudomelanoma, again, it's called pseudomelanoma because on path, you have some areas that may look worrisome. So typically these have a trizonal arrangement. So in the deep dermis, you've got a dermal melanocytic nevus. In the mid dermis, you have a scar. So you have this east to west parallel collagen with no melanocytes. And in the superficial area, confined to the area of the scar, you have what looks to be like melanoma in situ. And it's the way that the melanocytes are kind of growing back into that reestablished or reepithelialized junction. There's a lack of reedy ridges, so it looks like flat, and that can be a worrisome pattern for melanoma in situ. And you have this single proliferation of cells. Some of them are nesting, some of them are pagetoid. You could have circumscribed nests at the dermal epidermal junction, and they're not very equidistant. They vary in size and shape. You can have single melanocyte proliferation that mirrors contiguous growth, and you can have even suprabasal pagetoid spread. So that sounds like melanoma in situ, but you have to know the history that this was biopsy before, that there's no melanocytic proliferation beyond the scar, and that you have that trizonal arrangement of the deep dermal melanocytes, the mid-dermal scar, and the superficial area that's confined to the scar. So here's an example. Looking at that junctional component, you may be worried right off the bat that it looks very similar to a melanoma in situ. You might think that these are nests with pagetoid upward migration, some areas of contiguous growth. You have this mid part of the trizonal arrangement, which is that scar there with the east-west collagen, and then a deep dermal melanocytic pigment there. So the trizonal arrangement is the superficial junctional component, the scar, and then that deep dermal component. And these nests do not proliferate beyond the level, the area of the scar. And so that would allow you to help make the diagnosis. But let's say that the scar was limited to here, but the junctions went 3 or 4 times the length of that scar away from the scar, and the normal collagen was below. That would become more worrisome. So this would be a good lesion to maybe do a PRAME on and make sure that that PRAME is negative. Again, I'm not advocating to rely completely on PRAME. I'm just saying you can use it as a tool. You could also maybe send it for molecular testing like FISH or some type of NGS analysis to examine whether or not it has a melanoma related signature. Moving on to a pretty challenging aspect of dermatopathology, and that's the Spitz nevi family. So Spitz nevi used to be known as benign juvenile melanoma because they essentially on pathology looked like melanoma counterparts, but in young patients. They can be spindled cell, they can be epithelioid cell, they can be a mix of the two. Classically, the presentation is you have a pink to red dome-shaped papule. They can occur anywhere on the body of pediatric patients, but the classic locations are the face of children, as well as the lower extremities of young women. They most commonly occur in the 1st to 2nd decades. And histologically, they can appear atypical, and they might be difficult to distinguish from a melanoma. Here's just a few examples of clinical Spitz nevi. So you can see on the panel A, a classic Spitz nevus, most frequently occurring on the face. B through D shows you more examples of Spitz nevi with that pink to red, well-demarcated dome-shaped papule architecture that can sometimes even be ulcerated. Panel E shows you that the minority of Spitz nevi are pigmented. F and G show you that dense blue-black pigmentation can be characteristic of the pigmented spindle cell nevus of Reed. And if you were to look on dermoscopy, you would often see a very starburst pattern on these lesions. Panel 8 shows a patient with multiple Spitz nevi that are rare, and they often occur within a hyperpigmented patch, such as a cafe LA macule. So some patients have this agglutinated Spitz nevus development, which appear as several pink papules together. On pathology, the Spitz nevi usually show epidermal hyperplasia with hyperkeratosis. They have vertically oriented fascicles with large spindle to epithelioid melanocytes at the dermal epidermal junction and papillary dermis. They have this appearance of raining down or bananas on the tree pattern. And you'll see when you look at the histopathology what I mean by that. There's oftentimes dramatic clefting between the nest and the keratinocytes, which are most prominent over the apice of the junctional nest. That clefting can make it look very bad to the untrained eye. And so you have to have a suspicion that you're looking at a Spitz nevus before you start to assign too much worry to that cleft artifact. Spitz nevi are classically characterized by these caminobodies, which are eosinophilic globules of basement membrane material that resemble colloid bodies. They are above the tips of the dermal papilla in 60 to 80%. You can have focal pagetoid spread in the center of these lesions. They may have telangiectatic blood vessels in the superficial dermis, circumscription, and the symmetry and the lack of marked cellular atypia allow you to put this more in a Spitz nevus category as opposed to a atypical spitzoid tumor, which is an intermediate form in between a Spitz nevus and spitzoid melanoma. So you can have spitzoid melanoma in young kids, and that's the thing that you don't want to do is diagnose something as a Spitz nevus, when in reality it was a more malignant behaving spitzoid tumor, a typical spitzoid tumor, or a spitzoid melanoma. So we have several key immunohistochemical stains we do to work these up, in addition to the H&E architecture assessment and the cytology assessment. But we also have not only IHC, but we have molecular testing at our disposal too, such as basically chromosome array. So you can test to see if there's a gain or loss in different chromosomes, or you can do single nucleotide polymorphism array, where you can look for changes in the SNPs across Spitz nevi and look for signatures that are associated with atypical spitzoid neoplasms or Spitz tumors, as well as spitzoid melanoma. Spitz nevi cytologically show large spindle to epithelioid cells. The size of the cells, more than any other feature, sets the Spitz nevus apart from common nevi. So they typically have larger cells. They've got regular vesicular nuclei, prominent nucleoli. They have abundant eosinophilic cytoplasm. Oftentimes the nests are expanding the papillary dermis. There's mitotic figures in 50% of these Spitz nevi, but they can have usually a low mitotic rate, and they're rare in the lower half of the dermal component. The maturation of these cells are uniform at any given level of the nevus as well. So here's an example of a junctional Spitz nevi. You see these large epithelioid cells. They look like they're raining down from the sky. They're like bananas hanging down from a tree. They've got enlarged retraction artifact. When you have these collections of eosinophilic globules within the epidermis, that is known as caminobodies, but you don't always have to see them. And so this is a classic junctional Spitz nevus. Compound Spitz nevi can show the same epithelioid enlarged nests, even some areas of pagetoid spread, retraction. But the dermal component is sometimes large to where it becomes a sheet-like growth pattern, a little bit of an ill-defined nesting pattern, and you can find scattered mitotic figures in here as well. Now, if you were to stain this for a panel of immunohistochemical stains, what would you do? So you could do a SOX10 and a melanA just to prove it's melanocytic, because there could be some mimickers, but that's of low priority. But let's say that's the first thing you do is a SOX10 melanA just to prove that it's melanocytic because of the eosinophilic cytoplasm. There could be mimickers. So you do that. You can do a BRAF V600E. So BRAF V600E by definition should be negative. That mutation should be negative in a Spitz nevus. It could be commonly present in normal nevi or melanoma, but it should be negative in Spitz nevi, at least the classic Spitz nevi. You can do a P16 stain, and P16 is usually retained in the nuclei of benign Spitz nevi. If it's significantly lost in Spitz nevi, that becomes more worrisome. So P16 is the product of CDKN2A gene. And if you lose the P16 expression, that usually puts a brake on the cell cycle. You'll have a tendency to have overproliferation. So a complete loss of P16 is very worrisome. Checkerboard expression can be somewhat normal or intermediate, and full homogeneous nuclear retention is a reassuring factor. You could do a PRAME, obviously, but PRAME in Spitz nevi has been shown to be expressed in some Spitz nevi, even though the molecular came back not supportive of melanoma. but it is a pretty good screening tool because if you have diffuse praying positivity in a spitzoid lesion, that becomes pretty worrisome for an atypical spitzoid tumor or even a spitzoid melanoma. There are papers that compare the praying expression with molecular findings, and there's pretty good concordance, but there are exceptions to every rule. And so you have to take it by a case-by-case basis. I typically work these up to say, if PRAME is diffusely positive, I will go ahead and get molecular because I find that molecular is the final call. And so if there's diffuse PRAME staining, but the molecular supports a benign phenotype, I may just call it atypical or benign, but we still need to note that PRAME expression because that typically correlates with increased proliferation. And so to learn more about these tumors, we need to be recording that when we're doing that testing to learn more about the molecular biology of Spitz tumors in general. So you could also do a Ki-67 melanate to look at the proliferation rate of these spitzoid tumors. So if you have something on the order of 10% or higher, that becomes pretty worrisome as well. You could do a BRAF, we already discussed the BRAF B600E, but you could do an HMB45. So an HMB45 being diffusely expressed or expressed in deep parts of the lesion is more worrisome for an atypical spitzoid tumor or even a spitzoid melanoma. So those are a host of stains that you could definitely do when you're working at the Spitz nevus, but at the end of the day, these are often in children and they're high risk diagnoses to miss, and you want to make sure that if there's any doubt at all, I encourage you to utilize molecular testing to look for signatures of atypical spitzoid tumor or even spitzoid melanoma. Because if it's an atypical spitzoid tumor even, it can still have risk for metastasis, and spitzoid melanoma definitely has a risk for metastasis. So the research in this field is heavily dynamic and evolving. And so we're going to be learning more and more about spitzoid neoplasms, especially with molecular testing and more basic science and translational research in the future. Pigmented spindle cell nevus or nevus of Reed. These are darkly pigmented uniform dome-shaped papules. They most commonly are located on the extremities. There's about 70% of them are located on the extremities. They peak in the third decade, and they are much more common in females than they are in males. You may clinically and histologically have pigmented spindle cell nevus that mimic melanoma. So it's important to have a high index of suspicion for this diagnosis. You don't want to call something a melanoma if it's just a pigmented spindle cell nevus of Reed. It's thought by some to be a spindle cell variant of a Spitz nevus, and it's mainly junctional. So here's the clinical. You see this very dark macule or papule with this kind of starburst extension to the pigment at the edges. And if you were to look on dermoscopy, that starburst pattern would be even more pronounced. Pigmented spindle cell nevus of Reed on pathology looks similar to the morphology of the Spitz nevus, where you have spindled but not epithelioid cells, but they're heavily pigmented melanocytes. And I will go back and say you can definitely have epithelioid nests there, but a lot of times you have the spindled population. That's where you get that pigmented spindle cell name. But the key feature is that these are heavily pigmented melanocytes, and they usually do not involve the reticular dermis like a normal Spitz. So here's this pigmented spindle cell nevus of Reed. You can see it's largely in the junction, maybe a little bit of pseudo extension to the superficial reticular dermis, but it could just be in the plane of section. Nevertheless, it's all kind of concentrated at the highest part of the specimen. And you have these spindled pigmented nevus cells that are forming these large nests with some retraction around that. Another example of a pigmented spindle cell nevus of Reed. Hope you can appreciate that dense melanin aggregation across the nest from side to side. But there's no cytologic atypia here. There's no mitotic figure activity, significant mitotic figure activity, not significant pagetoid upward migration. It's just these large nests composed of spindle cells that are heavily pigmented with abundant retraction artifact. So when you're comparing Spitz versus Reed nevi, it's important to think about the Spitz nevus being mostly in children, whereas the Reed nevi are mostly in young women. Spitz nevi are usually pink, whereas the reed nevi are usually dark brown. Spitz nevi are usually located on the head, whereas reed nevi are usually located on the legs. Spitz nevi usually display hyperkeratosis, hypergranulosis, and pseudoepitheliomatous hyperplasia, as well as do the reed nevi. On the cytology, though, they differ because the Spitz nevi have large spindled and epithelioid cells, whereas the reed nevi have small spindled cells. Spitz nevi have communobodies very commonly, whereas reed nevi only have them variably. And Spitz nevi often show buckshot scatter in the epidermis, which can be normal in the center part of the lesion. And reed nevi also show that same feature of normal central buckshot scatter of the melanocytes in the central lesion. A halo nevus is one of those recognition diagnoses. So you can see clinically there's a halo around the nevus, and then on pathology, it looks like an abundant lymphocytic population that's obscuring the nevus population. Halo nevus are also known as Sutton nevi or leukoderma acquisitum centrifugum. Any type of nevus can be surrounded by a symmetric area of depigmentation, and that's what characterizes the halo nevus. There's a characteristic time sequence. So first you have the appearance of the halo, and then you have a disappearance of the nevus over several months, and then repigmentation of the nevus 1 to 2 years later. In general, these occur in patients with overall increased number of nevi. They can occur in adolescents and young adults. They're often immune mediated. They're usually benign. You can have destruction of these lesions with the immune system attacking the nevus cells. Approximately 20% of the individuals with halo nevi have vitiligo, and they're rarely associated with melanoma. So here's that clinical of the halo nevus. You can see a really nice white halo around this nevus, and that's where that abundant lymphocytic inflammation is causing a decrease in melanin production around the nevus. Multiple halo nevi can be associated with piebaldism and c-KIT mutations. On pathology, you see a banal nevus, but you also see dense lymphocytic infiltrate. It obscures the underlying nevus. You've got reactive atypia in the melanocytes, and apoptotic melanocytes are commonly present, but there's no high-grade atypia, and mitosis are absent. So here's this lymphocytes just pretty much mixing up with the nevus. It's hard to even tell that there's a nevus under there. It almost looks like the static picture that you would see in an old TV when it was disconnected from the signal. So this is also known as lymphocytes mixing with melanocytes in a cocktail party fashion. So this is just that intermingling of the lymphocytes with the melanocytes. This very characteristic picture of a halo nevus. Moving on to a balloon cell nevus. Balloon cell nevi are present in young adults as flesh-colored red or brown nodules. They're mostly common on the head and neck. They're characterized by cytoplasmic vacuolation resulting from melanosome degradation or degeneration. And in the absence of melanin pigment, it may be distinguished from a xanthoma. So you can think about a xanthoma, which you'll learn about later, as having this kind of foamy cytoplasm among histiocytes. And that clear cell cytoplasm with that vacuolation can look very similar. But you can do an S100 stain or other melanocytic marker stains and demonstrate that these are, in fact, melanocytes that have the clear cytoplasm and not histiocytes. Now, these can actually both express CD68, which can be confusing. CD68 is a histiocyte marker, but you shouldn't expect a large expression of CD68 or CD163 in balloon cell nevi. You should be able to see a SOX10 expression, S100 expression, other melanocyte markers. So you can see how this would be easily confused with a xanthoma. You've got these abundant epithelioid to ovoid cells with large cytoplasm, large clear cell cytoplasm, and it's a ballooning in terms of the architecture. So that is the balloon cell nevus, and these are actually melanocytes. At the top, you can see that these look a little bit more like melanocytes, but then they have this transition into a more ballooned up cytoplasm. So this would be difficult to tell balloon cell nevus just by looking at it. So you definitely want to do some IHC to look for SOX10 or melan, but definitely SOX10 should highlight in these nuclei if they're melanocytes. You could do an S100 as well. Meyerson's nevus is something that's forgot about a lot, but it's essentially when you have irregular nevus, but you have eczematous dermatitis superimposed on the nevus here. So you can see this scaly, almost nummular dermatitis that's existing on top of the nevus. So the eczematous dermatitis presents clinically as an erythematous, itchy, scaly border. The lesions are frequently multiple, and particularly they affect the trunk and the proximal limbs. And on pathology, what you normally see are just regular features of a nevus, but you have overlying spongiosis of the epidermis, and you have plus or minus a lymphocyte population with some exocytosis and maybe some eosinophils as well. Here's the histopathology showing a nevus embedded here with this kind of spongiotic epidermis overlying it. The reason why it's important to be aware of this is because your differential diagnosis for this could be different than just a benign nevus. You could be thinking like a seborrheic keratosis, or you could be thinking some type of melanoma if there was some pigment incontinence or hyperpigmentation of the stratum corneum that might make you be more worried about it. And so understanding that you can have eczematous type change over a nevus. That being said, if there's clinical concern at all and the patient's concerned and you're concerned, then just push for a biopsy. So that way you can prove to yourself that it's just a Meyerson nevus. Here's another example of this kind of, it's hard to see at this power, but you can see intermittent perikeratosis, which is often associated with an eczematous process, and then the surrounding acanthotic and spongiotic epidermis. It's possible that they could be having just atopic dermatitis or dry skin, xerosis, contact dermatitis, things that are responsible for eczematous processes, and it could be overlying a normal junctional or compound or even intradermal nevus. Finishing up the lecture with an entity called Nevus of Nanta. So Nevus of Nanta is essentially a nevus with osteoma or bone formation. You have, these are actually occurring mostly in females, way much more than males. They often exist on the upper body. Here's an example of a Nevus of Nanta. So it's kind of hard to tell what it is, a non-specific papule of some sort on the face of this Caucasian female here. And when you biopsy it, you can see it's basically a nevus up here, but you have this focus of osteoma cutis and calcinosis cutis within that, within the dermis as well. So that is a example of Nevus of Nanta. Just a few questions here. So the risk of malignant transformation in this nevus is going to be 3 to 12%. So this is a congenital melanocytic nevus. Keep in mind that the large congenital melanocytic nevus that are greater than 20 centimeters are at higher risk for malignant transformation. The gene most commonly associated in terms of the mutation with this lesion. So this is a blue nevus, and the most common mutation are going to be GNAC or GNA11. This lesion can be associated with which of the following. So this is a melanotic macule, and you can often see these in Peutz-Jeghers. All right, well, thank you for your attention.